All right, everyone, ready for a deep dive. Today we're tackling something pretty fascinating. Idiopathic normal pressure hydrocephalus.
NPH.
NPH, yeah. And we've got some great research lined up.
Oh, yeah.
Definitely. We've got the latest guidelines from the Japanese Society of Normal Pressure Hydrocephalus.
Wow.
A critical review focusing on INPH clinical features and even a deep dive into the lymphatic system's role.
Nice.
So by the end of this, you'll be spotting INPH left and right and making the best decisions for your patients.
Absolutely. It's one of those conditions that can be tricky.
Yeah, like it hides in plain sight.
Exactly, especially in the early stages.
So how would we define INPH in the clinic? For those who maybe need a refresher.
Right. So INPH is a neurological disorder where cerebrospinal fluid, or CSF, accumulates in the brain's ventricles. And it's interesting because the pressure isn't always high.
Right. Normal pressure.
Yeah, hence the name. But this buildup still causes problems leading to the classic triad of symptoms.
Gait disturbance, cognitive decline, and urinary incontinence. You got it.
But our sources say that not every patient has all three.
Oh, definitely.
Or they can be pretty subtle, especially early on.
For sure.
So let's break it down, starting with gait disturbance.
Okay.
What should make us think INPH gait versus just normal aging?
Good question. It's not just any walking problem.
Right.
Think shuffling, short steps, wide base, almost as if their feet are stuck to the floor.
Like a magnet.
Exactly. Magnetic gait. It's a hallmark of INPH.
Oh, wow. That's a great way to picture it. Now, what about the cognitive side? It's not like the memory loss in Alzheimer's, right?
Nope. More like slowed thinking, difficulty planning, trouble with executive function.
Like multitasking.
Exactly. They might struggle with making decisions too.
Okay, so more of a mental fog than actual memory gaps.
Yeah, you could say that.
And then there's the urinary incontinence, but with a specific twist.
Yeah, it's specifically urge incontinence.
Yeah.
A certain gotta-go feeling.
Oh, so that's what sets it apart. It often gets overlooked as just a normal part of aging, but with the other symptoms, it's a big red flag.
So even with one or two of these symptoms, we should still think INPH.
Yeah, absolutely.
Especially because our sources suggest it might be more common than we think.
Yeah, some studies estimate it could be up to 6% of people over 65.
Wow, that's a lot of people.
And think about the impact on their lives and the healthcare system.
Yeah, that's definitely a wake-up call. Now, speaking of history, our sources mention Hakim and Adams, who were pioneers in the field.
Oh, back in 1965?
Yeah, they found that shunting CSF, draining that excess fluid, could really help.
They were onto something. One of their early cases, the patient's shunt malfunctioned after a fall.
Oh, no.
And her symptoms came back full force until they fixed it.
Wow, so it really showed the impact of treatment.
It did, but as our sources say, that initial excitement led to sort of an existential crisis.
Why?
Because not everyone responds to shunting, and it created this divide between believers and non-believers.
Oh, wow, real debate.
Yeah, and that's what really pushed more research into INPH and figuring out who would benefit most from shunting.
Okay, so that brings us to diagnosis today. Let's start with imaging.
All right, so imaging, especially MRI, is crucial. We see ventriculomegaly, enlarged ventricles.
Got it.
But it's not just about big ventricles. We need to look for specific patterns, like disproportionately enlarged subarachnoid spaces.
What's that?
It's called DESH, and it helps distinguish INPH from other things that can also cause big ventricles.
So we need to know what we're looking for.
Exactly.
Now, what about lumbar puncture? Does measuring CSF pressure give us a clear answer?
It can help, but it's not always straightforward. A normal opening pressure doesn't rule out INPH.
Interesting.
Remember, Hakim and Adams initially thought pressure might be temporarily elevated, causing these B waves.
I see.
But even with fancy monitoring, not everyone responds to shunting.
Okay, so we need more than just a snapshot of pressure.
Exactly.
This is where those provocative tests come in, right?
Yes, they can help predict shunt responsiveness.
Okay, tell me more about those.
So provocative tests show us how a patient responds to CSF changes. The classic one is the TAP test.
Okay.
We remove a good amount of CSF and then just watch them for a few hours, see if their gait, cognition, or bladder control gets better.
So we're basically getting a sneak peek at how they might respond to the long-term drainage.
Exactly. A positive TAP test is a good sign, but a negative one doesn't necessarily rule out shunt responsiveness.
So it's a piece of the puzzle, but not the whole picture.
Right. And then we have external lumbar drainage.
Okay.
That's where we continuously drain CSF for several days and monitor the response.
Oh, so it's more continuous.
Yes, it gives us a much clearer picture of how the patient reacts to CSF removal.
So for complicated cases, that can be really helpful.
For sure.
And then there's the lumbar infusion study. That sounds a bit more technical.
It is, but it's basically measuring resistance to CSF flow.
Oh, interesting.
We infuse fluid into the lumbar space and watch the pressure. That tells us how compliant the system is.
So it's like checking the pipes for any blockages.
You got it. High resistance means a stiff system that might not respond well to shunting.
Wow, these tests provide a lot of information.
They do. They help us figure out who will really benefit from shunting.
That's great, because then we can make the best decision for each patient.
Exactly.
Wow, this is already so insightful, and we're just getting started.
I know, right?
We'll be back soon to dive into the world of shunting and explore some new frontiers in INPH research.
Looking forward to it.
Stay tuned. All right, so let's talk about treatment. We know shunting is the gold standard for INPH.
Yeah.
But it's not always a simple solution.
That's right. It's a big procedure with risks and benefits, so we have to be careful.
Okay, so for those who aren't familiar with the details, can you break down what shunting actually is?
Sure. Basically, we're creating a detour for the extra CSF to flow away from the brain.
Got it.
We surgically implant a shunt system,
Okay.
which has a catheter in the brain's ventricle, a valve to control the flow, and tubing to direct the fluid to another place to be absorbed.
So we're redirecting the CSF, but where does it go?
Good question. It doesn't just hang out in the body. There are different types of shunts,
Okay.
each with a specific destination for the CSF.
I see.
The most common one is the ventriculoperitoneal shunt, or VP shunt.
Okay.
It drains the fluid into the abdomen where it gets reabsorbed.
It goes back into circulation.
Exactly. There's also the ventriculoatrial shunt, or VA shunt, which drains into a vein in the neck that goes to the heart.
Okay.
And then there's the lumboperitoneal shunt, or LP shunt, which drains from the lower back to the abdomen.
So many options.
Yeah, the choice depends on the patient and their anatomy.
Right, so a tailored approach is important, but how effective is shunting really?
Well, that's the big question.
Right.
It can be incredibly effective for some patients.
Oh, what?
Like their gait, cognition, bladder control, all improve significantly.
Like a complete turnaround.
Yeah, but it's not a guaranteed cure, and results can vary.
So not a magic bullet. What affects those outcomes? Isn't just how severe the INPH is?
It's more complicated than that.
Okay.
Patient selection is key, the more classic the INPH presentation.
Meaning?
All three symptoms, clear ventriculomegaly on imaging, and positive responses to those provocative tests.
Ah, I see.
The better the chances of success.
But as we said before, INPH can be tricky. It can look like other AIDS-related things.
Absolutely.
So a good assessment, and those tests are really important.
For sure.
Are there other factors involved too?
Yeah, definitely. One thing is that INPH often happens alongside other neurodegenerative conditions.
Like Alzheimer's.
Exactly, or vascular dementia, and that makes it hard to tell which symptoms are from INPH and which are from something else.
Oh, wow. So it becomes a much more complex picture.
Right, and those other conditions can also affect how well shunting works.
Interesting.
Someone with severe vascular dementia might not see the same improvement in cognition after shunting as someone with just INPH.
So we need to look at their overall neurological health.
Definitely.
Before we get too far into treatment, let's talk about this glymphatic system.
Oh yeah, it's fascinating.
You compared it to the brain's cleaning crew taking out the trash.
Right, it clears out waste products.
So how does it relate to INPH?
Well, new research suggests that problems with the glymphatic system might actually contribute to INPH.
Really?
If it's not working well, those waste products can build up and make things worse.
So it's not just about how much CSF there is, it's also about what's in it.
Exactly.
And how well it's being cleared out. That changes our understanding of INPH.
It really does, and what's even more exciting is that researchers are looking into CSF biomarkers.
Biomarkers.
Yeah, specific molecules that might help us diagnose INPH earlier.
Oh.
And even predict who will respond to shunting.
That'd be amazing. We could know who needs shunting before their symptoms get too bad.
That's the idea. But for now, let's get back to current treatments. Are there any new developments with shunting?
Good question.
There are. Newer adjustable valves give us more control.
Control over.
Over the CSF flow, we can fine-tune them for each patient.
Oh, that's great.
It helps avoid complications like overdraining or underdraining.
So it's customized.
Exactly. But we have to remember that shunting is still a major procedure.
Right.
Thorough evaluation before surgery, careful technique during surgery, and close monitoring after are all crucial.
So it's a team effort between neurologists, neurosurgeons, and other specialists.
Absolutely. And clear communication with the patient and their family is really important too.
About?
about the benefits and risks of treatment, answering their questions, making sure they understand everything.
So they can make informed decisions.
Exactly.
This deep dive into INPH has been so informative, we've learned a lot.
Me too.
But get ready, because we're about to explore something even more mind-blowing.
Oh.
We're going deep into the glymphatic system and what it means for the future of INPH treatment.
Can't wait.
We're back and ready to explore the glymphatic system.
This is where things get really interesting.
Yeah, it's like the brain's cleanup crew, right?
Exactly. The glymphatic system is all about waste disposal, keeping the brain running smoothly.
And you mentioned that it's most active during sleep.
Right. It's like the brain uses that downtime to do a deep clean.
Makes you wonder if sleep problems could be a factor in INPH.
That's a great point. It's like if you don't take out the trash, things start to pile up.
Exactly. It's not just about the CSF volume, it's about what's in it and how well it's being cleared out.
Absolutely. It really changes how we think about INPH.
So how does this affect our approach to INPH, both diagnosis and treatment?
It opens up a whole new world of possibilities. Imagine being able to assess glymphatic function without being invasive.
Wow, that'd be amazing. We could diagnose INPH much earlier.
Exactly, even before the classic symptoms show up.
What about treatment? Could we target the glymphatic system directly?
That's the big question, and research is exploring different options.
Like what?
While things like lifestyle changes to improve sleep quality and maybe even medications that could boost glymphatic function.
So we might be moving beyond just shunting and focusing on helping the brain clean itself.
It's a very exciting area of research, and the potential is huge.
It definitely gives us hope for new treatments that could slow down or even reverse INPH.
It really does.
But even with all these new developments, what can we do right now to improve patient care?
The first step is awareness.
Awareness of?
Of INPH, we need to make sure healthcare providers know how to spot the early signs and consider it as a possibility.
So asking the right questions, paying attention to gait, and not dismissing those seemingly minor changes in cognition or urinary function.
Exactly. Early detection is so important.
And if we suspect INPH, then what?
A full evaluation is crucial, with a neurological exam, imaging, and maybe even those provocative tests we talked about.
Like the TAP test and external lumbar drainage.
Yes, they can tell us a lot about whether shunting...